great in their Zoom rooms.
Mm-hmm.
Welcome, everyone. I am Donna McKay, the Executive Director of Physicians for Human Rights, PHR. And I want to thank you for joining us today for what is our 33rd conversation in our COVID-19 expert discussion series. Since we launched this last March, PHR's webinar series has provided a space for healthcare workers, scientists, and researchers, advocates, and voices from the front lines to examine and speak to the implications of the pandemic through the lens of science and overall health and human rights. We have over 500 people live with us today to listen to our esteemed panel discuss the critical urgency for vaccine deployment worldwide, the collective interest in prioritizing at-risk and underserved populations in vaccine allocation, mitigating vaccine hesitancy, and the critical importance of vaccine efficacy. It's so much to cover, but our panelists represent a very rich set of experiences and expertise. So I want to get us started. I am absolutely thrilled and honored to welcome back today's moderator, Dr. Chris Beyer, who returns to our series as a second-time moderator. Dr. Beyer is the Desmond M. Tutu Professor of Public Health and Human Rights and Professor of Epidemiology, International Health, Behavior and Society, Nursing, and Medicine at the Johns Hopkins Bloomberg School of Public Health. He's also the director of Johns Hopkins HIV Epidemiology and Prevention Science Training Program. Chris is a past president of the International AIDS Society and was elected to membership in the National Academy of Medicine. His voice and engagement has been absolutely critical during the pandemic, and Chris has been serving in an essential role of senior scientific liaison to the COVID-19 Prevention Network, established by the National Institute of Allergy and Infectious Diseases. As someone who's built a momentous career dedicated to health and human rights, we're just so fortunate to have Chris serve on PHR's advisory council. And so, Chris, thank you so much for moderating and bringing this panel together today for this conversation, and I turn it over to you.
Well, thank you, Donna, and welcome everybody. It's wonderful to be with you all, and I really want to commend Physicians for Human Rights for establishing this platform and really creating a space where we can debate not just and discuss the scientific issues that are so fundamental and important, but also these relationships of what is happening with COVID-19 to social justice, to human rights, to equity. And that really is the focus of our conversation today. I'm going to ask some specific questions of our wonderful panelists to get us started. But before I do that, I just want to say a few things about where we find ourselves. I think probably in every home and every household on this planet, people are debating and discussing and asking, when are we going to have access to these vaccines? When will our grandparents be able to be protected from this terrible virus? And the answer to that is that we are in an enormously challenging moment in every society and as a global community. And that moment is that we are seeing, unfortunately, very high rates of community transmission. We now have at least two approved in the US for emergency use authorization, highly effective and seemingly, with all the data we have so far, highly safe vaccines against this virus. But we are in a period of vaccine scarcity. So we have high transmission with high rates of hospitalization and unfortunately loss of life globally. And we have very limited supplies of effective vaccines. And that scarcity is going to continue. We have more vaccines in the pipeline that are coming along. We're expecting approval, again, emergency use authorization of at least 2 more products fairly soon in the US and in other countries. But the reality is we are going to be in this period of scarcity for a considerable amount of time. And the weight that is the reality that all of us are living through about when we're and our loved ones are going to be protected is not equally distributed. So there are places like Israel that have achieved 30% of their population, at least within Israel, immunized. And then there are other places where, the expectation is it might be not until mid or late 2022 that there will be vaccine access. That is enormously challenging. And of course, within societies, these inequities have emerged. The COVID health disparities emerged very, very quickly in the United States. Dave Wilson is here, who is a member of the Navajo Nation, who's going to talk to us about those issues in tribal communities where those health disparities emerged very quickly. But now that we actually have interventions that work and that can protect us, those disparities in vaccine access and in immunization and in allocation are front and center in all of our minds. And that's what we want to focus on today and talk about today, and also hopefully talk through what might be some of the ways that the global community can really come together and try and address these inequalities and try and address these social justice issues. Because the bottom line scientifically is also the bottom line for humanity, and it's the bottom line for human rights, which is that until everybody is protected from this virus, and by everybody we mean everybody, we're all vulnerable. And we cannot leave out either communities within wealthy countries or whole parts of the low and middle income countries from vaccine access and somehow expect that we still will be protected. This won't work unless we have a global strategy and we can implement it as quickly as is humanly possible. So I'm going to stop there, and I'm going to turn to ask the first question from my longtime friend and colleague, Marine Boussonnier, who's an independent consultant now, but working closely with Results to Save Lives, particularly in the DR Congo, which maybe is one of the countries where we're most concerned about vaccine access. Marine, maybe you can speak from that perspective and from the work that you're doing about what you see as really the challenging issues in terms of low and middle income country access to these life-saving products.
Many thanks, Chris. It's a truly great honor to be on this panel, and I'm really excited about this conversation. I think the question that you started to hint at, which is the issue of global allocation of scarce vaccine, is the one that's really been on my mind from where I work. I think all of us were particularly excited and elated when we first heard that the COVID-19 vaccines was showing signs of effectiveness late last year. But at the same time, that news was already tinted by the knowledge that richer Western nations had been reserving and buying up vaccine doses. For some, actually, many times more than what they would be need to actually vaccinate their citizens. And to give a sense of the scope of the issue of what I'm talking about, for all the talks of solidarity, rich country bought about 96% of vaccine doses from Pfizer and BioNTech, and more than half of the most promising vaccines overall, de facto cutting off sources of supply for low and middle income countries less well positioned to negotiate and less well positioned to exert power to have access to those scarce resources. The Economic Intelligence Unit estimates that as a result of such what has been known as vaccine hoarding, COVID-19 vaccine will likely not be widely available for Africa until 2022, 2023. Now in Africa, where COVID-19 is surging back right now, at least 2.5 million healthcare workers should be protected immediately, and this should not be considered unachievable. Yet the likelihood increases day by day that younger, healthier adults in richer countries will be vaccinated before health workers, before older people in poorer countries. Now, what will be the consequences if this is not addressed? Well, clearly the failure to address equity early on and to address vaccine allocation based on health and epidemiological needs rather than national interest is now promising to have a dire impact on the world's collective ability to achieve rapid global control of COVID. And it is actually truly confounding that wealthier nation thinks that hoarding vaccine is the best way to protect their people from a global pandemic that does not respect borders. I think, we've seen many recent studies, commissions. The last one, I think last week, was released last week, commissioned by the International Chamber of Commerce, which concluded that equitable distributions of vaccine was in every country's economic interest, and prior study had shown that that was the best way as well to reduce mortality. So I think in failing to ensure that people in the developing world gain access to vaccines, leaders in wealthiest nations are not only displaying questionable humanities, but they're also damaging their own fortunes. So I think that's the general picture, Chris.
Thank you. And I think that's such an important point.
Yeah.
Ali Mokdad is with us. Ali is a professor at University of Washington in the Institute of Health Metrics and has really been doing extremely important work with modeling and projections of the trajectory of the COVID pandemic, and probably one of the most widely used projection models. Ali, we've had a conversation about the timing of the challenges and the staging of the challenges. So, for example, right now, it is scarcity that matters so much. But down the road, it may also be hesitancy when we actually have enough vaccine. So maybe I could ask you to speak to the kind of how you see the stages and the projections going forward. I think that would be helpful for everyone.
Thanks, Chris, and thank you, PHR, for having us for this important topic and timely topic. Yes, right now in the United States and most Western countries, wealthy countries, what we are facing is a shortage of vaccines. So we have vaccines enough for the people who want to take them, or less than what we need. But a couple of months from now, what will happen is we will have more vaccines available, but we will have a hesitancy. And right now, when you look at the global hesitancy, and in the United States specifically, we have about 50% of Americans who said we are willing to take the vaccine. 25% of Americans 18 and above said, I am not sure if I will take it or not. And 25% said, I will not take it. It varies by state. So that's a big concern, especially with a vaccine and a disease that's so transmittable right now, and you want to reach a herd immunity. You can't afford to have about 50% of your population to start with saying, I will not take the vaccine, or I'm not sure. Also, your vaccine is only given to 75% of your population, since people who are under 18 or 16 are not eligible for the vaccine. So herd immunity is really being affected right now unless we deal with the vaccine hesitancy on the long run.
Thank you. Thank you. I think that's a very important insight. I'm delighted to ask the next question of my dear friend and colleague, a mentor of mine, Ruth Faden, who is a professor of bioethics at Johns Hopkins and is the founder of the Berman Bioethics Institute at our university. And Ruth, you've been playing such important roles in the ethical issues that are really at the heart of this allocation challenge. And I wonder if you could speak to that and to how you see the ethical dimensions, particularly of the global allocation that you've been in your advisory role.
And thank you, and thank PHR for inviting us and for having this panel. I would say that Maureen made the ethics case for global allocation quite eloquently, effectively describing the tragic circumstances that we're currently in. There were such high hopes, maybe naive high hopes in the very beginning, sort of building up to this pandemic, and then the establishment of COVAX, which we'll discuss, I'm sure, later, but as an international entity that was intended from the outset to forestall exactly what we are now experiencing. So let me just say one thing about global allocation and one thing about the relationship between hesitancy and access and equity. So in terms of the global allocation context, the case for the global responsibility of wealthy nations on equity and human rights grounds has been made. I'm happy to rehearse the core arguments. Again, Maureen has signaled all of them. They have been made. They have to do with the recognition that while in the world as it is, the world as we find it, and we don't have a perfect global order, we have a deeply flawed global order from the standpoint of structural justice. But even in the world as we find it, with states having primary responsibility for the protection and fulfillment of the human rights of its residents, that does not absolve states as everybody listening at PHR knows, does not absolve states of moral responsibility for the human rights of people living in other countries who are not positioned by where they are situated to have their human rights protected and fulfilled. There is no question that access to this vaccine is a human right. There's no question that this vaccine is suppressing essentially every core element of well-being that is the basis, in my view anyway, for human rights. And there's no question that the unfairness in advantage and in power that exists globally is just once again making the situation, which was already terrible, awful. So the two key arguments now are exactly as Maureen has signaled them. Continue to try to make the global ethics argument for why countries should see beyond their own borders, trying to help countries understand how to hit that balance between obligations to their own countries. And in fairness, it's really hard right now, especially with the new variants coming up and the fear that that's generated and the reality that that's generated. It's really hard to understand what a country needs. And I'd love to hear Ali's thoughts on this, but what a country needs in terms of protecting its own interests, which really translate to the human rights needs of its own residents, and what they can and have an obligation to ensure happens simultaneously elsewhere in the world. In terms of within country challenges, there is this tension between short supply and hesitancy, exactly as Ali describes it. One of the concerns, though, is if we wait for the supply that's available to be used up by the willing, we are likely to exacerbate the inequities that already exist in terms of the disproportionate burden of the pandemic on, for example, in the US, but it's not unique to the US, disadvantaged communities. And I know Dave is going to speak specifically to this, so I'll hold off on that. But the problem, of course, is, as we're seeing throughout the US, the uptake of the vaccine, except where there's been exceptional work, which we'll hear about shortly. But throughout the US, we're seeing a disproportionate uptake, totally predictable on more and more affluent and majority white populations. And that is causing just significant concerns in this sort of dual effort to get vaccines efficiently out there as quickly as possible and also be attuned to the background inequities that this pandemic, as you indicated, Chris, have surfaced.
Thank you, Ruth. Oh, as always, such a clear articulation of the issues. And I think it's a very nice lead-in to Dave Wilson. So I'll ask the next question of Dave. For those of you who don't know him, Dave is the director of the Office of Tribal Health at the NIH, which sits under the Office of the Director of the NIH. He's a member of the Navajo Nation. And he and I have been working together on what's called the CoVPN, the COVID Vaccine Prevention Network, on community engagement and on these health disparities issues since maybe March or April. Dave, was when we started working together. And you're one of the people that I consider a new friend that I have only ever met virtually. I so look forward to the day that we can actually meet, but it's been wonderful working with you. And I wonder if we could turn now to our own country for a moment, the enormous health disparity that emerged among our tribal nations, and the efforts that really happily now are starting to change those dynamics with the community engagement effort that you have been so instrumental in.
Yeah, thank you, Chris, for the opportunity. And we really appreciate, again, the opportunity to be on the panel here today. So there's one thing that we've always had to combat, and that's history. And there have been many historical examples where research, and this just doesn't apply to tribal communities, it applies to many other minority communities and other communities abroad, where research hasn't been always the best partner. Lots of examples of unethical conduct in research. So that was, I think, one of the first challenges that we had to think about and had to face, are the realities around mistrust. And you talked about rebuilding trust in science. And that's really one of the big things that we've had to do initially in the outset of our approach to addressing the pandemic for tribal communities. I think something that's critically important to realize as well is that there are 574 federally recognized tribes and about 66 to almost 70 state recognized tribes. So, and these are all independent sovereign nations that have their own customs, traditions, and cultures, languages, governmental structures. So it's just like working with a foreign nation inside of the United States of America. One of those, and I think it's really important for us to think about how we engage these independent and sovereign nations with respect, and think about effective collaborations as we talk about not only clinical trials, but vaccine uptake and vaccine hesitancy. I think one of the things that we've been most clear, and I think has had the greatest impact, is increased communication and building trust, that we have been seen as a trusted partner for reliable information as it begins to develop or continues to develop. As we all know, the pandemic is changing hourly. And so to be able to provide validated, accurate information to these communities when they ask for them has been critically important. An example of our effectiveness in this approach is that I have been engaging with a lot of the tribal councils. Tribal councils are their independent governing councils that make decisions for these communities. And going into these councils and having conversations, describing the different platforms and how they work has been really effective for us. So early on, Moderna, because it was the first to come out of the gates and launch so rapidly, it kind of passed everybody by. You know, the vaccine trials, and everybody turned their heads and Moderna was already behind us. But, and so that was a good starting point for us. And in that trial, they report as having about 0.6% of their 30,000 enrollees as AI, and that pans out to about 180 participants. With Pfizer, we've had a little more opportunity to engage community, the tribal communities, and inform them about this upcoming trial. Within that, we saw moderate increases, around 250 participants in that trial. But I think what I'm really happy to report is that with the recently launched Novavax trial, they are currently around 14,000 participants. They launched in early January. They're enrolling 1,000 individuals a day. And right now we are over 2.5%. So we're already at 360 plus participants. This is in part due to three clinical trial sites that were launched in the Great Plains and in the Pacific Northwest to specifically provide opportunities for these communities to participate. Now, because I think our efforts around communication engagement have been so successful that now we're beginning to shift, and we're beginning to move over into the vaccine scarcity and the issues with access. The Navajo Nation, which has been a good partner of ours, we've had town halls with Dr. Fauci with them. Their vaccine implementation rates are absolutely astonishing. So the doses that they've received, they've been able to vaccinate or use up 80% of their vaccine doses on hand, and which is just a phenomenal rate. But again, we're moving into that phase where we have people who are willing to get the vaccine, but we don't have the vaccine available. So this imparts another challenge, which I think is a greater challenge for us in the federal government, but I think as a scientific community as a whole. So I'll stop there. Thanks.
You know, Dave, I'm mindful of one of the images that you shared on a recent conversation with our community engagement group about at the Navajo Nation. You know, the lines of cars of people bringing their elders, because the elders play such an important role in the culture and as preservers of culture, language, history.
Mm-hmm.
Yeah, absolutely, Chris, and I think that that's one of the biggest reasons why the traditional community within all of these other tribal nations are very supportive of the vaccine, because they see the efficacy, they've heard of the research, and they understand it and they trust it now. And they see this as a way to preserve not only culture, tradition, but also language and the stories of evolution. So it's a really important part of our communities right now.
Mm-hmm. Ruth, you alluded to the COVAX facility, the COVAX mechanism, and I think we probably should spend a moment on that. Yeah. Maureen, I know you also have ideas about that, but maybe for folks in the audience who are not familiar with it, Ruth, you could give us a kind of thumbnail of what it is. And
I'll try, and I'm happy, Maureen, to come in at any time and back me up on this. So COVAX, and for that matter, Ali and Dave as well, and everybody, like, come in as you want on this one. So COVAX, and I have to remember what it decodes into, but it's vaccines, right? Is part of something called the ACT Accelerator, which is an acronym for yet something else. But basically, it's an institution that was set up specifically in response to the pandemic by European Union countries, the Wellcome Charity in the UK, Gates, Gavi. I'm sorry, I'm throwing out a soup of initials here. CEPI. This is not helpful when you take one thing and you sort of explain it in terms of a bunch of other alphabet soup initials. But basically, it was a group of institutions, and the WHO, of course, a group of institutions who were responding initially to the disaster that Maureen and others here could speak about, that was the attempt to mount a vaccine effectively and successfully and in a timely way for Ebola, and also recognizing the failure with H1N1 and globally in terms of access. The whole idea was we can't do this way again, right? We have to have some other way so that we know we don't once again face a situation in which vaccine is widely available in wealthy countries, and by the time it's available in low and middle income countries, essentially the threat's gone. And that would be, and the devastation has been allowed to just run amok in parts of the world. So this institution was set up, and the idea behind it, short compass, was to essentially find terms that would engage self-interest on the part of countries who would be paying countries, as well as put a floor under the countries that are typically supported in their vaccine initiatives through Gavi, and figure out the kind of right levers, the right incentives, and the right pushes, and the right investments to get this structured up and fast and running. It has 4 areas that it works in. Vaccines is one, that's COVAX. It also works on therapeutics. It also works on diagnostics and on health system readiness. So there are 4 pillars to the ACT Accelerator. COVAX is the one that was designated from the beginning to address this lofty goal of equitable access for all peoples of the world to the COVAX, to whatever COVID-19 vaccines became available. It functions kind of like Operation Warp Speed functions for the countries that are part of it. It creates a portfolio of vaccines, which are vaccine candidates in the R&D pipeline, which investments were made, in exchange for which countries sort of diversify their risk in terms of not knowing in prospect which vaccines are going to come in. So it's got a structure a little bit like Operation Warp Speed, but that's where it stops in terms of analogy. It doesn't have the money, it doesn't have the coordination, it doesn't have the reach, and it has this mandate, which is global. So right now, I believe it's something like $2.4 billion US has been raised for COVAX, but it's estimated that they need another 6.8 billion, something in that order, by the end of 2021. Please, anybody who can correct the numbers, please do, because I'm like pulling this out from memory. But that's basically the dynamic. Originally, it was hoped that 20% of population coverage for all countries that are part of the COVAX facility would be received by the end of 2021. That no longer seems, no longer seems likely. Mm-hmm. And at the same time, countries who have joined into the COVAX facility, and there are 98 or 99 or so high-income countries and 92 low and middle-income countries. It's basically almost the entire world, right? Nearly all the countries of the world have recognized, sort of seen the sort of handwriting on the wall, and the kind of Hopkins or Hunger Games, or whatever way you want to describe what is going on at the global level here in terms of the scramble for vaccines that Maureen was signaling. There have been, COVAX has been sort of overtaken by a very large number of bilateral arrangements between countries, including middle-income countries, but also some upper, lower-income countries, directly with vaccine manufacturers, supported in some cases by the World Bank, it's a mess. It's like sort of a mess. So that's sort of my official technical description of what is going on in the global market right now. It's like a mess. And the bottom line is, it is a kind of Hunger Games type scenario out there in terms of who's getting access to what. At the same time, COVAX continues to persevere. It needs money, and it will be the primary source of COVID-19 vaccines for many countries in the world.
Yes, if you allow me to comment on something Ruth said.
Please.
Ruth said something about our role here in wealthy countries to make sure that we are aware what's circulating in other countries. Otherwise, we'll have a new variant that will come here, like the UK variant, the South African, and now the Brazilian variant. So to our interest as wealthy countries is to immunize everybody else globally, because this will be circulating and mutating and will come back and hunt us here. Even if we vaccinate all our public and we reach that herd immunity and it's circulating somewhere else, it's gonna come back and hunt us again. So that's very important. So the discussion should be for all these wealthy countries is the moment that they bought a lot of vaccines at risk because they didn't know which one will work, and they paid for some development of these vaccines. And now you have all these vaccines and we know they are working. So the debate should be today, all these rich countries should sit together and have a plan. At one point of time, you start diverting vaccines to where? You need to divert it somewhere else. So we need this plan right now, like a protocol, how to vaccinate our own public, protocol, how to vaccinate the rest of the world. That's working with the countries, of course. And not only sending the vaccine, technical supervision or technical advice, WHO, Gavi, and others, to make sure we do it equitably everywhere else. So we don't support something that's not right. We don't do in another country what we're not doing here internally for our own country. So it's very important to our advantage to move as soon as possible, moving our vaccines that are surplus. A vaccine is 0% effective sitting in a refrigerator, irrespective of what the clinical trial is saying. And we need that plan today. Over.
Wonderful. Thank you. Marie?
Yeah, I've been chewing on COVAX because, like everybody, I think that COVAX was our best shot as an equitable distribution. I think COVAX, which came with an equitable framework for distributions to priority groups, for allocations across countries, seemed at some point like the best incarnation of the solidarity that we could collectively crystallize. And yet, it's been falling behind in number of doses that it can claim to, have in financial support, as has been described by Ruth. And now you find yourself in the situations where countries, regions are frustrated. The African Union has begun to try and take matter into its own hand and secure deals of its own, because it's realizing that waiting for 20% of its African populations to be vaccinated by the end of 2021 is not satisfying. It's not going to cut it. And I don't think we're talking enough about the other way of addressing the scarcity of vaccine is to look at how to increase manufacturing capacity. And I think there's been reluctance to go into that direction, which of course will make some people uncomfortable, because you would have to start talking about IP rights and technology transfers, all things that the number of countries that number of companies that are currently holding a piece of the pie or share of the pie are not necessarily open to look into. But I don't think we can avoid this conversation, because 2, 3, 4 companies are not going to solve the problem of scarcity over the short run. And we need to start talking about increasing manufacturing capacity, decentralizing capacity in a much more robust fashion than what we've done until now.
I think that's absolutely right. And that actually is, Dave, yes.
I just want to add that it was reported yesterday that Sanofi is actually beginning to produce the Moderna vaccine. So under the Defense Production Act. So that is beginning to take place, but it's not moving fast enough, like you said.
Yeah, no, that's a very important point, because
development,
Sanofi had been working on their own COVID vaccine, and it didn't pan out in early phase trials. So that's extraordinary. And they're, of course, a company with a lot of experience. We have a number of questions now coming in the chat, and let me share one with you that I think would be really interesting as a follow-on, Maureen, to just what you said, but open to anybody. Should the pharmaceutical companies who have developed effective COVID vaccines with government funding be obliged to share how these are made, so these become free public goods, as some NGOs are pushing for? So that really gets to the heart of what you're talking about.
So I'll do a segue and I'll let other people do it. The Moderna vaccine was funded 100% through Operation Warp Speed. The public provided $1 billion to Moderna to bring the vaccines to market. It was developed by NIH scientists.
Yep.
And then UHD also paid an additional, I believe it's 3.2 billion to Moderna for 200 million doses. So the public has already paid multiple times for these vaccines. I think it's, there's a reasonable arguments to be made that it should, at this stage, have the public return on investment that was made and should be available publicly. But you know me, Chris, I'm a little bit, I'm very convinced about these issues. I'll let other members of the panel add the nuance that I certainly missed.
Well, I just want to say you're not further to the left than Sabin and Salk, because as you remember with the polio vaccine, it was free.
Yeah.
Also developed with public money. So we've done this before. Ruth, do you want to?
No, I actually don't disagree with Maureen. I am just struggling with how to get to that space. Everyone watched, I think, looking back, when Pfizer refused, right? Pfizer went ahead, refused is maybe too strong a word, but sort of said they would go ahead. Thank you very much. We're going to do this on their own. And that was in some respects, sort of a positive signal. Is wow, if that means, if a company as savvy as Pfizer wants not to have sort of a significant investment from the federal government in its R&D for its COVID-19 vaccine, it's worried, right, about limitations that might come down the road. And I went like, yay, what are those limitations going to be? What sorts of things are now going to be expected of Moderna at the other end of the spectrum? And that's, I think, exactly the core of your point, Maureen. It's like, so now what, right? So now what happens? And of course, we're all hugely grateful to the scientists and to Moderna in terms of everyone that worked so hard to get us this, get the world this fabulous, vaccine. But it's not the world's fabulous vaccine. At this point, it's pretty much wholly owned U.S. vaccine.
Mm-hmm. I think above that and on top of that is that it's important to consider the cold chain requirements for each of these different products. So I think, as we move down the line, Novavax would be maybe more of a promising global distribution type product.
Yeah, a very important point. We've had a question. I'm not sure who wants to take it, but I do think it's an important one, which has been raised about access to vaccines in the Palestinian territories in the West Bank and Gaza. Maybe I'll jump in and just say I have been recently with the Lancet Commission that we're doing on the future of global health and human rights, engaging with one of the leading Palestinian public health persons at Birzeit University. And she, has really talked about this just very challenging reality that they have been excluded from the Israeli national vaccine effort. There is no vaccine access in Gaza or the West Bank, and they are struggling now to do a bilateral and to try and access from elsewhere. And this gets to what you were saying, Ruth, about the fact that bilaterals are kind of superseding COVAX because people are scrambled. And if you don't think that the mechanism out there is going to deliver for you, you have to try other things. I mean, everybody wants these vaccines. Another question, which I think is really an important one, is the question about marginalized communities and particularly the displaced. So access for refugees. Are there initiatives out there, regulatory systems to try and ensure that these folks are not left behind? And of course, it goes without saying that we right now have more displaced people in the world
than ever before. Yeah. So who would like to take that? Happy and, you know.
So I am involved with the vaccine rollout in Lebanon. This is where I'm originally from. And the plan right now in Lebanon and in Jordan as well is to vaccinate residents. It doesn't matter if you are a citizen or not. So vaccinate everybody in Lebanon. That includes the Syrian refugees, the Palestinian refugees, and every other refugee in Lebanon. Because as I mentioned before, it's for the national interest of Lebanese. If you don't vaccinate everybody, you're not going to reach that herd immunity. So you have to vaccinate everybody that resides in your country. And that's what we're doing here in the United States. So we should also advocate for that in every other country as well.
Yeah. I should add that in the prioritization roadmap and the values framework of the WHO, both insist that the obligations of countries extend to residents and not solely to citizens of the country, and place a high priority. Now that's, you know, at the language of exhortation, not at the language of requirement, but it is a recognized high priority group in the prioritization roadmap for the WHO in terms of vaccine distribution within country for a complex of reasons, not the least of which is the high burden of disease in special humanitarian settings.
Yeah. Mary?
And Chris, yeah, just adding to that. So COVAX is supposed to have a buffer for humanitarian settings, which would generate some sorts of access to vaccines for particular populations which may not rise to the priority of a particular state or governments because they're on the move or because they're not necessarily on the top list. But I do think it raises the questions of prioritization once again, and the fact that we're concerned, we're aware that prioritization may end up being a functions of politics or wealth or power rather than a functions of public health needs or epidemiology. And I don't think that would surprise anyone, because I think that's a patterns that we've seen in other crises and we're seeing in this one. But I think that with the toll of COVID-19 and how it's taken a toll on a lot of the poor and marginalized people suffering disproportionately more than richer people, I think it should be high on our mental space and really the subject of priority policy actions.
Chris, is it okay for us to ask a question of one another, or
Sure,
are we bumping?
No,
So,
no, go ahead.
I just wanted to ask Ali if you see a path towards this global plan and protocol. I agree with you completely. I'm trying to see how to get there, right? And
I've been vocal about it, Ruth, and we need to do it simply because when I was at CDC, we used to do something called the global disease detection, and the idea was to protect the U.S. citizens and the U.S. public is you catch it somewhere else, prevent it at the source, don't allow it to come here. So again, it's for our national interest. If you look at it from a selfish standpoint, it is well justified. We need to do that. And I haven't seen it. I mean, I've been pushing for it. We should sit down and have a plan to redistribute the vaccines within our own country as well. And, within the country, if somebody is giving vaccine, I did that during the 2004-2005 shortage of the flu vaccine. I monitored the uptake in the US and we redistributed. And if you remember, CDC has a policy delay and don't take it. And then mid-season, we changed the policy because we were able to monitor. We need the same here. And I published on that, but we don't have the global plan that we need to help everybody else. And right now it's a race against time with all these variants. We really need to step up and help each other. COVID-19 showed us that our strength is in our weakest. Look at that, what happened in the United States. We shut down meat processing and everybody was like, oh, I'm not going to have pork on my table. We should have protected our essential workers and we didn't. And every country in the world, we should protect them. Otherwise, it will come and bite us here much harder than what we have seen right now.
I guess I would just also want to point out before we go on to the next question that, of course, the former administration did not sign on to COVAX. We're not a part of it, which is, I think, a real challenge. And hopefully, as we return to full engagement, of course, the president has already moved us back into WHO. We will participate. I think that would really be reinvigorating for COVAX. In the Biden administration request for the next stimulus. There's 11 billion for global health, and that could certainly help close the COVAX gap. So I think that's important to say. This is a tough question, and I don't know, Dave, if you want to take it on, but we'll open it up. How are you seeing efforts to reduce racism as a public health issue, working to address the inequity in vaccine distribution?
So that is a terrific question. And how we're approaching it is our efforts to develop more culturally appropriate materials for these different communities to review and for them to have confidence in and want to get more about and learn more about, you know, not only the pandemic, but how the vaccines work, why it's important in multi-generational homes to practice the public health safety measures of masking and physical distancing. You know, we're trying to stay away from the social distancing term, but I think that is the way, and also reducing the literacy levels of a lot of the materials so that the communities don't have to have a background in science to really understand what these documents mean, you know, how they translate to their communities, how they translate to them as individuals. So that's, I think, how we've really been doing it. Not only at the NIH, but we have great partners at the Center for American Indian Health there at the Bloomberg School of Public Health, who we've been working in partnership to develop these materials.
Yeah.
Also, Chris, it's very important to involve minorities, people of color, brown, African American, Hispanic, Native American, early on in the design and what you are doing. Don't produce a vaccine without including them and without including them in the trial, proportionally to their size in the country, and come and say, take this vaccine. Involve them early on so you develop these materials that David is. I'm totally agreeing with David, and develop it adequately and say, hey, we've worked with you. This is our vaccine, not somebody else's vaccine.
Yeah.
Well, I just want to say, apropos of that the Moderna vaccine, of course, the Moderna was the company that took it to development, but the actual scientific work really began at the Vaccine Research Center at the NIH, and the head of that coronavirus group is a young African-American woman scientist, Kizzmekia Corbett. So we had an event with her and some of the Baltimore African-American community leaders just this week. And she is an extraordinarily impressive young scientist. She's one of 9 siblings from a small town in South Carolina. She got her undergrad degree at University of Maryland, Baltimore County, and then a PhD at UNC. And it really matters that people understand that an African-American woman is at the lead of this scientific effort. And by the way, she happens to be an incredibly compelling speaker as well. So remember that name, because she may end up, getting that little Nobel Prize thing. Kizzmekia Corbett. Okay. There's a question here about, will the Biden administration join COVAX? I guess I would borrow a phrase from Ali's language and say, Inshallah.
Yeah. Yeah.
Inshallah in our culture means sometimes no. You need to say yes. Naam.
Do the right inflection, perhaps, too. Yeah, it's hard. I've tried and
But
failed.
yes, they've committed to, Chris.
Yes, they have. Yeah. That was an early on action, along with joining the WHO, I believe, simultaneously, which is great, which is all great. But I haven't heard a dollar figure. Have you heard a dollar figure? No.
Just the 11 billion that's in the global health allocation.
Yeah.
I haven't seen a breakdown for that, but we know that
Right.
there's substantial resources
Yeah.
there. One other question, and Ruth, this is kind of so much in your area because of all the work you've done on the ethics of research with pregnant and lactating women, was just a question about inclusion of pregnant women in the trials and plans going forward.
Yeah. So how much time have we got? This is a story that has a long tail and hopefully a short future. The long compass is that although things are better than they used to be, even than they were with Ebola, we're still in a circumstance where the data on safety in pregnancy is lagging. So a couple of challenges: the reproductive preclinical studies with laboratory animals, which should have been initiated earlier in the R&D process, were not. So that when Moderna and Pfizer and even AstraZeneca started coming up for review by regulatory authorities, their packets did not all include final, what are called DART studies. And so that in some cases caused a hiccup. Despite sort of commitments and concern about including pregnant women as a phase 2 bridging study participants, not ever in the trials themselves, which for reasons we can discuss do make, I think, good ethical sense. There were no plans on the shelf, as many people had advocated, no protocols already ready to go with institutional review board approval until after these products had received emergency use authorization. So yet again, we'll start to accumulate data only now. We do have information from women who became pregnant despite they're not supposed to in the clinical trials. We know if you've got 30,000 people in a trial and maybe 15 or 10,000 of them are women of reproductive age, people get pregnant, right? No matter what you tell them. And so there's a bit of data coming from there, thus far reassuring, but not much out. And now we have a very large number, increasing numbers of women who are health workers who are pregnant, who have been receiving the vaccine in public health rollout programs. So we hope to get a readout from VSafe in the US and from the UK and from Israel shortly that will sort of bolster the evidence base. All of this is a long way of saying that right now, the situation in most countries in the world that have a vaccine to give out have taken the position that if you are pregnant and if you otherwise qualify, despite the fact that pregnancy is a risk factor in itself for more serious COVID disease outcomes, if you are pregnant and you are otherwise in a risk category like a health worker, or you have a significant other comorbidity like obesity, for example, or diabetes, that you should be allowed to take the vaccine. Basically an individual choice with your clinician if you have one. So it's a little bit short of a full-throated recommendation for pregnant women to receive the vaccine, just a little short of that because of the absence of pregnancy-specific data, but a permissive stance, recognizing that right now, given the risks of becoming ill, becoming infected and becoming ill with COVID-19 disease while pregnant, that for a lot of women who are pregnant, if vaccine is available to them, it probably does make sense. The benefit risk calculus does tip in the direction of getting the vaccine.
I just want to say that that's such a clear answer. So appreciate that. That as you were speaking, I got a text from Scott Gottlieb, the former FDA chairman. So apparently the Johnson & Johnson Janssen vaccine results have just been released. Ali is nodding, and it looks like I haven't seen all the data, but the early reports are that it's another efficacious vaccine. And folks should remember that this is a single dose.
One dose, yeah.
One dose.
I think the numbers on that are 89.5%.
Woohoo!
Yeah. Against the strain, be careful. I think the information is coming in differently for the different people.
Yes. We'll have to see, and we'll have to see if it comes in.
Yeah.
But
it's good news. I mean, it could have been
yeah. For somebody who I started my first job in my career after training at Hopkins in 1992 was to set up HIV vaccine trial sites in Thailand. And, we were talking about having a vaccine in 2 years. That would have been 1994. And here we are in 2021, and we're still don't have an HIV vaccine. So to have had so many of these trials, be successful in this really still in the first year, it's just breathtaking. And, I think I would just reflect in our last few moments that the biomedical research enterprise is a big part of what we have invested in. The messenger RNA technology has been a work in progress for almost 2 decades. And we are really seeing that incredible power of modern biomedical technology and research and development. But the public health infrastructure to roll this out and the ethical, social justice, and human rights issues that we've been dealing with for this whole hour are, again, really bedeviling us, both as a country and globally. And I think that that's a reality we really have to face. We have invested in technological fixes, and we've starved public health for 2 decades. And that's a huge challenge. So we only have a few moments remaining. I don't know if Donna McKay from PHR wants to come back and say a few words. But while we're waiting for that, I just want to thank everybody. Thank the panelists, Maureen, Ruth, David, and Ali. See, he may have dropped off.
Chris, can I answer a question that I see here?
Oh, please, Dave.
There's a question about the situation on reservations with respect to infection. And I want to say that early on, the Navajo Nation was absolutely very effective when they closed the borders of the nation over the holiday weekends and over each of the weekends, and just allowing essential workers to go in and out of the reservation. And that was extremely effective in reducing the amount of transmission early on in the pandemic. But now I think as we all have become fatigued, those kind of practices are only as good as the people who follow them. And so now the outbreaks in each of the different communities has really escalated, and it mirrors the rest of the country. So started off really well, but you can only do so much as the fatigue wears on in the communities.
Yeah, that's an important point. Donna, we have one last question before I'm going to ask you to close us out, and I think this is an important one. What might one do locally in an attempt to influence equitable distribution in communities and nearby communities? So a question about what each of us can do as individuals.
Yeah. Do you want me to jump in or something?
Sure, please, Ruth.
Yeah. So if we're talking really local, right? So if we're talking in your local communities, if you have any relevant skills, if you have any way to claim that you could be qualified to be an immunizer, then now is the time to step forward and offer your services. And there are all kinds of policy changes that are happening that are going to make it easier for people to do that. If you were licensed in a different state, if you retired, all that good stuff. If your training has lapsed, you don't have all those things. People are trying to waive those away. So that's one. If you are a person of color, or if you are someone who could otherwise be perceived as a trusted communicator in communities where there's higher degree of what we call justified distress, where people have good reasons because of the kinds of human rights and ethical conduct that Dave alluded to earlier, is the experience of any number of socially situated groups in the US. Now is the time to reach out through faith communities or otherwise with the on the ground effort that is happening to try to bring people to a place where they can at least consider taking the vaccine. And then finally, and I would let Dave and Chris, who are much more expert on that, speak to that. And finally, there's this thing about personal queue jumping. So there's lots of agonizing about, is it ethically okay for me to do X, Y, and Z? And this is a question I get asked more than anything, right? Is it okay? So there's a simple, my simple message here is follow the rules, right? Whatever the rules are in your jurisdiction, the best course right now is to follow the rules. If you think the rules are unethical or not fair, you should speak loudly about it and try to bring attention to it, but you don't change it by jumping the rules yourself. The situation I want to differentiate is that if you happen to be a person around when an immunizer says, I've got 3 doses left and they're going to go to waste and they haven't fixed that structural problem yet, there is nothing wrong with then taking advantage of that opportunity and going forward and assisting. That's not jumping the queue. That's just being essentially lucky from, something hasn't gone right in the program and you happen to be in the right place in the right time, that's fine. But don't jump the queue as much as you're tempted to, as much as you have someone you love and you want to help them. Don't fake an address. don't do a bunch of things that people are considering doing so that they look as if they live in a low-income neighborhood or a neighborhood that's disproportionately a minority when they are not.
Well, Donna, I think we're at the top of the hour. It's been a wonderful panel. I want to really thank Ruth, Maureen, David, and Ali, who jumped off, got knocked off, and over to you.
Chris, thank you so much. I think all of us could have listened for hours and followed the many threads that you all began. So I want to thank you, Chris, for assembling this incredible group of people and for moderating the discussion today. And I hope, and thank the panelists, I hope they'll all come back at some point because this was really, really it's so informative. You know, we passed the 100 million confirmed cases worldwide and 2.2 million deaths reported by WHO. And part of what was so important about this conversation today is the focus on the inequities that exist in our society, and they are sorely laid bare with this pandemic. Who is at risk of getting COVID, who has access to treatment, and ultimately who lives and dies. And this great opportunity that we have as a society to take advantage of this extraordinary scientific achievement and prevent this illness is similarly playing out right now. As you all articulated so clearly today in terms of vaccine access, it is one of the greatest challenges in front of us right now, and certainly one of the most urgent. And Maureen, I was so struck thinking about the situation that you described in Africa, whereby some 2.5 million health workers will not have access in the near term because of vaccine hoarding, and it's tragic, but it's not a done deal. And our global advocacy efforts are critical. So for one, PHR joined with other medical development, human rights organizations, and others in the People's Vaccine Campaign in calling for COVID vaccine to be free and fair for all people everywhere and prioritizing those most in need globally. As Maureen also pointed out, it was already paid for by the people. So we'll be reaching out soon with opportunities for all to join us. So stay tuned on that. And other things that listeners can do, share this webinar. It will be put back out, put it on social media and share it with others. Sign up for updates at PHR's website on actions that you can take. And join us next Thursday for our next webinar, February 4th at 2:30, where we will have a conversation with Dr. Tom Frieden, the former director of the U.S. Center for Disease Control and Prevention and former commissioner of New York City Health Department. So you can register at PHR's website. So once again, thank you all so much, especially to our panelists, and wishing you all to stay safe and continue your incredible advocacy.
Thanks, everybody.
Thank you.
Yeah.
Thanks, Chris, for great moderating. Thank you, Donna. Bye-bye all.